All right. Hi, everybody. Nice to see you here. Thanks for joining us today. Welcome to the rerun of Sonocyte's Behind the Scan webinar titled Diagnostic Shoulder Exams, Posterior Shoulder. My name is Chris Pennell, and I'll be moderating today's webinar. This is the third in a four-part series about shoulder ultrasound. And if you'd like to check out the previous webinars in the series, you can visit our webinars page on sonocyte.com. We'll be rerunning the fourth part of the shoulder webinar series, Superior Shoulder, on January 16th. And that will have a live Q&A portion just like today's presentation. With that out of the way, we can go ahead and get started. Before we begin, please be advised all attendees are muted. We'll conduct a Q&A session at the end of the presentation and demonstration today, and you can type those questions into the Q&A box in the toolbar located at the bottom or the side of your screen. And that is only for people on the Zoom call, actually. So if you are watching on YouTube or one of the other sites, you can join the Zoom call, and you'll be able to get your Q&A your questions entered in just for that. This webinar will be recorded and archived for future reference on our webinars page. Today with us, we have Daniel Shelton. Daniel is the Director of Musculoskeletal Market Development for Fujifilm Sonocyte. Daniel has spent 19 years as a dedicated musculoskeletal sonographer, and 14 of those years have been here at Sonocyte. He now leads musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. We'll go ahead and start the recording now. Thank you so much for joining us.
Today we're gonna discuss the posterior shoulder, specific to the infraspinatus and the teres minor, and we're also going to take a glance at the posterior labrum and what can be visualized there, and the spinoglenoid notch. Just a little bit about the anatomy on the posterior shoulder. Specific to infraspinatus is the origin being over this infraspinatus fossa of the scaphoid. Good palpation landmark, which we'll go over live, is the acromion process here posteriorly, and then the spine of the scapula. Basically, you're going to set your probe right under this posterior corner of the acromion. We have highlighted here how lateral this tendon goes when we're in a neutral position, which is what we're going to be scanning. And then we'll internally rotate the shoulder when we're scanning live with the patient's arm across their belly, and you'll see that this greater tuberosity travels very lateral. Here are the image differences between the more proximal over the glenohumeral joint, and then when we follow the tendon out laterally to its enthesis, what we actually get. So over the glenohumeral joint, we get this big comet-tailed shaped infraspinatus with a central tendon and surrounding muscle. It's a multi-pinnate muscle, and so the central tendon looks really nice because there's a little bit of muscle on top. Down below, we have the cortical landmark of the humeral head, and then the greater tuberosity's middle facet back here, more posterior. Here's the glenoid labrum, the posterior glenoid labrum, and then there's a joint capsule that's really, really thin right here, stretches from the superficial surface of the posterior glenoid labrum over and then underneath the infraspinatus, and then when we do our rotations, which we'll show live, you can actually see that joint capsule when you externally rotate and then when you internally rotate. And then back here, a little less clearly seen, is the spinoglenoid notch, and I think it's just better described in the live imaging, so we will go over the scanning technique for that to further clarify the anatomy. One pitfall when you're scanning the distal infraspinatus tendon, as that tendon wraps around, you may get this dark shadow in the center of the tendon, and very, very commonly you're going to be scanning under this little deltoid septation here. So this connective tissue here can lay down kind of an edge artifact on each of its sides, or just the sheer change in density going from a fluid-filled muscle on both sides to relatively less than fluid-filled, densely connective tissue structure. You're going to end up with a slight refractile change in how the ultrasound beam is portrayed here. So it's less attenuated superficially, and it may cast a darker version of the image, versus here we have this really nice fluid-filled deltoid, which is also enhancing the underlying tendon relative to what happens underneath the deltoid septation. Also here in the posterior deltoid muscle may enhance the tendon. So if you see a dark shadow there, just do a couple internal-external rotations. It may clear up any of the shadow in the tendon. You don't want to call this little margin of the tendinosis, for example. Here's our transducer location. Basically, you're going to palpate right under that posterior lateral corner of the acromion. And then I instruct people just to aim the beam into the joint. If you're already doing joint injections, just pretend the ultrasound beam is the trajectory of your scope or your needle, and you should be able to land an image like this. When we go to live scan, I'll show you the way to get an image really nice with the bones laying flat with our ultrasound beam. But this is a good dynamic maneuver when you're trying to evaluate for joint effusions. When you externally rotate, that capsule will unfold. Whether it's filled with fluid or not, you're still going to see this little capsule unfold, and it's very nice. So internal, external rotations will help you delineate these tissue margins. Also on external rotation, there's a vein that dilates, and we'll cover that in the live scan. Going to short axis, pretend this animation has flipped to a short axis of the tendon following these panes that have been superimposed over the animation. And the extreme proximal, more proximal than that posterior lateral corner of the acromion, we see this central tendon of the infraspinatus is not yet formed to the more dense solid tendon. So it's still kind of surrounded by its multipinnate structure of the muscle overlying the body of the scapula over the infraspinatus fossa, which is outlined here. This is the inferior glenoid, and we'll talk about that when we get to the teres minor, but it is a great landmark for you to look at the muscle belly. As we travel distally towards the humeral head, you will start to see a more dense central tendon and perhaps some cartilage here, and then you're going to get a lot of shadow from the acromion, and we're going to do some maneuvers in the live scan to get rid of those. And then distally, it's a frustrating view sometimes if you're not going to move the shoulder, but you're going to catch the enthesis of the tendon here over that middle facet of the greater tuberosity, and a lot of it may be overshadowed by the acromion. So we're going to want to raise the elbow up and drop that humeral head down a little bit, and we'll do that when we scan live. Long axis, switching this way, we're going to the teres minor now. You're going to follow that humeral head inferiorly. Remember when we were scanning the anterior shoulder specifically, when I told you every time you translate the transducer down, because we're scanning the surface of a ball, you have to aim the handle down as well, which directs the beam up so that you stay 90 degrees to the surface of the bone. So we're trying to stay 90 degrees to the surface of the cortex of the humeral head and its inferior facet here. And whether you're internally or externally rotated will get you the difference between these two images here. So internal rotation, you get this really nice feather-shaped muscle. For a joint injection, for example, this is a great place to land your needle, not under the infraspinatus because of that real hard pop that you would get with that large central tendon. So if you could find that deltoid, or not the deltoid, if you could find the muscle bellies of either the teres minor or the inferior muscle belly of the infraspinatus, your needle will slip right through the muscle easier without that hard pop. And because we're using ultrasound guidance, the need for loss of resistance technique in injection is much less. But we're just taking a look at the very much more inferior teres minor here in long axis, and then we'll switch over to short axis. These are numbered out of order on purpose. The short axis view can be kind of frustrating for a lot of people at first. So can the long axis view, honestly. But if either view is difficult for you, what I would instruct you to do is just find that posterior humeral head neck junction here, just like a hip. And this will be your cortical landmark. And there at that posterior margin, you're going to see the teres minor here sitting in that head neck junction, just like you would in a hip if this were the joint capsule or something like that. Here we have the deltoid overlying this, and then up here the infraspinatus, most inferior margin. And then from there, you just want to go translate the entire transducer either towards the scapula, which you'll catch the inferior margin of the glenoid here, and then come back to your home base of the humeral head neck junction posteriorly, and then slide laterally to catch that inferior facet. So here we are at the enthesis of the teres minor, and highlighted I've got the muscle belly of the teres minor, the distal muscle belly of the teres minor here at our kind of landmark centrally, and then the tendon of the teres minor, most distal and lateral. And remember, we're scanning the surface of a curved object, so you want to stay 90 degrees to the cortical landmark here. But the triceps tendon makes a really nice landmark as it inserts. This is the long head of the triceps. It inserts to the inferior glenoid as well. It'll kind of hold the shape up of the teres minor. Let me go back one slide. No, or not. Let's just go to the live demonstration. I couldn't get my slide to go back, and we'll just cover those two tendons plus the posterior glenohumeral joint, as well as the spinoglenoid notch. So just a second while we get things transitioned over.
All right, so now we'll move to the live scan, and today we're going to be scanning on the newly released Sonocyte PX. I'll be starting with the L15 to 4 megahertz transducer, which is the overall general musculoskeletal exam probe. And then for some of your patients to get a little bit larger than I would say like my shoulder, you may want to opt to the curvilinear for the posterior shoulder, especially in injections. This is a curved 5 to 1 megahertz transducer. So if there's time at the end, we will switch over to that. But for now, I just want to point out my most frequently used palpable landmark, which you should always start with a skeletal reference point if you can. This is that posterior lateral corner of the acromion process. And I just want you to reach back here on your own shoulder and feel for that little bony prominence, because we're going to use it for the majority of this exam. What I like to do, and I'm going to keep screen left medial for this exam. What I like to do is palpate that bony landmark, set the upper part of the probe, this surface and long axis across that lower edge of the acromion. So I'm actually physically bumping that up against the acromion. So I'm just going to set the transducer down right here. And then if you're already doing injections in a shoulder, the direction of your beam will be relatively exactly like you do a glenohumeral joint injection. If you're not familiar with this anatomy, on the anterior part of the shoulder is the coracoid process, and you can feel that with your finger right up here, and you'll basically point your beam towards the coracoid. But the upper margin of the transducer is just rested against the inferior margin of that posterior lateral acromion point, this little prominence on the back. And then I'm just going to rest the palm of my hand on the top of the shoulder so I can scan comfortably. What we should see, and without even looking at the screen, I was able to see all of this, or I expected to see all of this, was the humeral head first. Let's pull the arrow up. So cortical landmarks are key. If you get a blurry image like this, and you see what vaguely looks like a bone down there, you're going to tilt the transducer until you get a nice, sharp, hyperechoic bony cortex. In this case, it's the humeral head, articular hyaline cartilage, and then this little white area here is the joint capsule. I'm going to follow the cortical landmark deep until we can't see it anymore. And I'm going to bring my depth down just a click or two. There. And then point out the next cortical landmark that we rely on, which will be the posterior glenoid tubercle here. So this is the posterior glenoid tubercle. And then back here, if we keep following the slope, is the infraspinatus fossa of the scapula. And then above this is infraspinatus muscle and central tendon, one of the pinnate directions of the central tendon. We'll get to the rest of the tendon momentarily. So between the humeral head and the posterior glenoid tubercle, we have this labrum here. This triangular fibrocartilage of the labrum is shown really nicely on ultrasound, just in the posterior shoulder. Don't rely on ultrasound for anterior labrum. Don't rely on ultrasound for inferior or superior labrum. But posteriorly, if you see some pathology back here, you're probably not far off whatever the diagnosis is leading to. If you suspect labral pathology back here and you do maneuvers and everything looks normal, but the patient's clinical presentation is that they may have some sort of instability, or if your clinical exam is pointing to labral pathology, don't rule it out with ultrasound. You still need to rely on a standard MRI for labrum. With that said, we will continue to examine what we can see back here. And what we're going to watch now is how to evaluate for a joint effusion of the posterior shoulder. If we don't already see a protruding joint effusion coming out from under the joint capsule here and spilling out posteriorly, let's see if we can cause one by doing a dynamic maneuver. And what I'm going to have our patient do is just slowly externally rotate, and we're going to watch that most posterior middle facet of the infraspinatus attachment come back here and almost bump against the labrum. And then here's our labrum. I'm going to we've changed some densities there, and it's not as nice because the overlying infraspinatus is not really shining over the labrum. So I'm just going to bump my gain up in the far field. There we go. And then let's point out what we're seeing here. So the labrum is now this blunted edge instead of that sharp triangle. And then just above that blunted edge, here's the capsule that has redundantly folded posterior and more medial here. So I'm pointing at the capsule's interface. This is the central tendon of the infraspinatus. We have gone into external rotation, which has brought the enthesis posterior. So this is the anatomical position. If you're looking at an anatomy poster or book, when we're in external rotation, we expect to see the infraspinatus back here. Thing is, when we do these exams, typically the patient is in a relatively neutral position. So let's watch where the infraspinatus goes. I'm going to get off track here. And we're going to chase, I'm going to rotate our shoulder for the camera here. That way we can chase this probe direction down all the way anterior, and we're actually just following the enthesis of the infraspinatus so that you get a general sense of just how anterior it goes. Remember, it's the neighbor of the supraspinatus, right? So here I am on the most anterior part of the lateral shoulder, as we did in our lateral shoulder webinar, and you can see that the infraspinatus looks a lot like a supraspinatus, except it doesn't have that inflection point of the greater tuberosity anteriorly. If I were to keep going anterior, you'll see supraspinatus has this inflection point on the greater tuberosity. As I go posterior, you'll see the greater tuberosity flatten out. We get a lot more acromion in the shot because the infraspinatus is going to dive under it. Now let's follow the infraspinatus central tendon posteriorly now until it's there laying over the joint here. I don't see it laying over the joint very well, which is okay. Sometimes you can just have the patient grab their opposite shoulder, and that will cause the infraspinatus and the humeral head to inferiorly drop. So there I do see that central tendon really nicely, and it makes it easier to evaluate the long axis of the infraspinatus tendon. So counting our layers underneath here, we've got glenoid, humeral head, here's that posterior labrum, and then let's watch this joint capsule under the infraspinatus kind of unfold itself. I'm going to keep our patient's elbow down to her side here, and then she's just going to slowly externally rotate, and let's watch this joint capsule unfold. Here we go, right there. And then let's internally rotate. Okay, and then it's folded and tightening over the articular hyaline cartilage of the humerus. Now let's externally rotate again. And this is where I'm looking for debris, calcium deposits to pop out of there, loose bodies, all kinds of things can just be shoved into this joint recess. But you can see that little fold right here, and it's a normal joint. And then internally rotate. That's where we would see a big joint effusion.